So I'm Megan Hadley. I am the Fisher & Paykel representative. So celebrated 3 years, which is crazy because it's been a whirlwind. It's been awesome. I've seen high flow in particular really kind of sort of being used to now just exploding, and it's being used everywhere. And that's why you guys are here today, because now you're going to try and use it in your truck. I live in Reading, so I'm not terribly far from you. If you ever need anything, reach out to Adam. I know Bren's messaged me too. I try to get back to you the same day too. So my goal today is just to kind of do a brief overview of what nasal high flow is and how is it different than regular oxygen, or how is it different than CPAP, BiPAP, and then just get you comfortable with the disposables that we'll have for you guys to use and answer any questions that you have. So anything that sounds confusing along the way, just stop me and we'll answer it as we go. So what is nasal high flow? To keep it short and sweet, nasal high flow is heated and humidified oxygen. And because it's heated and humidified, you can go higher flows, all right? Typically coming out of the wall, it's cold, dry air. Nothing's heated and humidified from it. I always say you could do the test yourself. If you put about 15 liters on your nose, after a while, that gets cold, that gets dry, and you kind of want to take it off. Or my grandma, for example, when I go to see her in the hospital, she has it sitting on her head because she says it's uncomfortable. We can go higher on the flows now for these kids because we're heating and humidifying it, okay? It is an open system, it's not a closed system. So anytime we're putting these cannulas in the nose, we don't want it sealed. We want it about 50% occlusion. I'm gonna give you little guidance charts too to kind of show, based on the size of the prong, does this make sense? We also have, based on the weight of the kid and based on the age of the kid, does that particular cannula make sense for that child, okay? How does nasal high flow work? Well, because you're giving higher flows, you can help wash out the upper airway a little bit more effectively to help clear out that CO2. So when the child's breathing in again, they're breathing in more oxygen enriched air rather than rebreathed CO2, because you're washing out that upper airway much more effectively. Airway hydration, again, we heat and humidify it. Fisher & Paykel heaters make water vapor, okay? Water vapor is different than water molecules, for example, because bacteria can't latch onto this and carry up to the patients. Water vapor is so small that it penetrates farther down and helps to break everything up. So it does an excellent job of heating and humidifying the upper airway and following it down to the patient's lungs to keep everything mobilized and moving. Dynamic positive airway pressure. So with this device, we're not setting a pressure, you're setting a flow. Rule of thumb for adults is for every 10 liters of flow, you get about a centimeter of pressure. Now that's give or take, depending if they're a mouth breather. It's gonna be less. If their mouth is closed, it's gonna be a little bit more. But the main thing to know is with high flow, we're not setting any pressures, you're just giving a flow and then bleeding in some FiO2 to do that. And then supplemental oxygen, again, we find sometimes that these kids benefit because they're going higher on the flow, so you're helping, we won't switch that on there. That we're helping to open up the airway a little bit more effectively. And sometimes when we go higher on the flows, you might not need as much oxygen because you're getting that flow support, okay? So that's kind of a very simple way to explain how is high flow different than what you're used to using with standard oxygen. Where does it fall in the continuum of care? Well, right now you have basic oxygen therapy, and then you have CPAP or intubation. This is the bridge in between oxygen and CPAP. For you guys in the ambulance, it's going to be much more easier to manage because you're not going to have all these parts and pieces with CPAP that's involved. And to kind of put some proof there too, there's a lot of studies that are saying, based on the kid's gestational age, what makes sense for this kid. Now, obviously there's going to be some outliers, but rule of thumb is the primary treatment, if they're less than 28 weeks of age, CPAP is the go-to. Research is supporting though that between 28 and 32 weeks, you can start with nasal high flow first and then rescue with CPAP if need be, okay? So they were non-inferior to each other. And then 32 weeks and above, again, high flow is the preferred method, and then rescue with CPAP if need be. But Kim can attest to this. If they clearly need the pressure support, then you're gonna choose the CPAP method. But if they're in that gray area that you know they could just benefit from the flow and a little bit of the heat and humidity and oxygen, high flow is the way to go for them, rather than just standard oxygen. This kind of just shows you why high flow has taken off. Barely any studies being done. I started around 2014, right at the end, and then we saw the spike, okay? So really started taking off and continuing to have more and more studies coming out to this day. Not gonna bore you with all of these here, but if you have time over the holidays, you can sit down and read all of these. But where it really hits home is this one, the Franklin study. And this talks about kids that come into the ED with bronchiolitis. So this is why you might be getting calls from some of those other hospitals that can't keep kids there on high flow and they're transporting out. What this study did is it focused on 1,400 patients, which is huge. Usually when we talk about randomized controlled trials, it's maybe about 200 patients or 300 patients. This is 1,400 patients, largest to date that focused on nasal high flow for kids. Took place in 17 emergency departments, and they said, are kids gonna benefit more on standard oxygen or high flow when they come into the ED with bronchiolitis? And what the study supported is that kids that were just placed on standard oxygen, 23% of them failed, but the kids that were placed on standard or nasal high flow, only 12% of them failed. So this is why you're seeing the momentum for kids that come into the ED, getting them on high flow, transporting them on high flow, and staying on high flow, because they're gonna have better results and less therapy failure on that, okay? How long does high flow take to work for kids? This doesn't really apply to you because literally you're just getting them from point A to point B. But usually we say for kids, it's about 60 minutes. So there's two reasons why high flow fails with kids. Number one, they're not aggressive enough on the flows. So they start them at 2 liters when really the kid should be at 15 or 20 liters. And I'll talk about how do you know what flows are appropriate. For you guys, usually the physicians or the clinicians are gonna be telling you, hey, put them on this flow or put them on this FiO2. Another reason why it fails is because they'll put them on nasal high flow in the ED, they give it about 10 minutes and they're like, oh, it's failing, we gotta go to something else. But they didn't give them time to see it really do the job. So for kids, just rule of thumb, it's about 60 minutes. That's as long as it takes. And if that doesn't work, then you need to go to the next mean of therapy. How do we know high flow is working for these patients? Well, you should see their respiratory rate improve, their heart rate improve, and work of breathing improve. If you don't see that happening and you didn't max out on the flows, then I would say, again, another mean of therapy would be suggested. I'm gonna slide through this real quick, but rule of thumb for you guys is 2 liters per kilogram per minute. Would you say that's typically what you follow? Are you a little bit less than that, Kim, or?
That and or more.
And or more, yeah, awesome.
Yes.
When is your cutoff that you follow that guideline? Like how many kilos do you follow that up to?
That's a good question.
Putting you on the
I don't
spot.
know the answer to that.
Well, that's Dr. Schibler right there. Rocking out. You're fine. So this is Dr. Schibler.
Dan's having a narcoleptic attack and he has to wake up.
He did that Paris trial that I just talked about with the kids that came into the ED with bronchiolitis. And this is kind of his rule of thumb. So kids 0 to 15, 2 liters per kilo per minute. And then patient weight 16 to 30, he's 35. I think that's a little high compared to what I see in this area. But Kim said sometimes higher.
I most of ours are like, once they get to be like adult-ish patients.
Right.
So that where they would go on an adult Optiflow,
then you would go on the higher.
Starting at like 20 liters a minute anyway.
Yeah.
So if you're talking like maybe an 8-year-old, a 6-year-old, somewhere around there, how much do they weigh? I don't know. How much does a 6-year-old weigh?
The Lehigh Valley?
Yeah.
They weigh 60 pounds.
Right.
But this should be ideal body weight though, right? When you're really.
No.
Yeah.
Or
No, you're gonna have to use actual body weight.
Oh, I'm
if
sorry.
Yeah. If you're talking your kids are like you're gonna need more flow to move that. So.
I don't know because lung volume is still lung volume.
Yeah, but you're also talking about your impedance from
work
you know.
breathing. Yeah. Again,
or
this
shoot
is
for the
guidance. Yeah.
So technically, because it's an open system,
Right.
that's why we're going with your theory, Kim?
Yeah, because you're not actually providing CPAP. So, some of these kids that are, especially if you've got a big belly and, they're laying on the ground or they're laying down or whatever. Yeah, that's all just pushing on their lung volume.
Yeah.
So you need something to just basically fight back. So, yeah.
Yep. So, and I always, with this too, everyone says, what's the risk of pneumo? That's, I think, everybody's fear at first. So in that study that was just done, they had 1 pneumo that occurred in the standard oxygen group and 1 pneumo that occurred in the high flow group. So very low, but our goal is we're not occluding the nares. That's the main thing. It's open, there's nothing sealed that's going on their face. So the risk is very, very low. And then here's your guidance chart. So up to you how you want to remember. If you want to go by colors, sizes, critters, we have all the options for you. You will not be using the blue. So that's considered our micro preemie size, but you'll have the small, medium, large, extra large. I know this is really tiny to see, but this is the guidance chart based on their weight and based on their age. So can I blow it up? Ooh, that better? What makes sense for this kid? And obviously you look at the nair size too at first.
Does that say it on the package?
It does not. We ask for that all the time. The problem is we have different systems that this could be used on, and this would get really jumbled trying to read it. So I'll get cards laminated for you that you can keep in there, and it literally has this on there, and it shows our fitting guide, how to apply it. Keep in mind this is guidance. So you're gonna have some outliers on either side, absolutely. But for the most part, put it on.
You're
Does it
gonna
make
see
sense for
mostly
this kid?
these purple, like an infant kids, you're gonna
Yeah.
see mostly the purple. And then if it's like a, 2-year-old or whatever, you're gonna see the green.
Yeah.
You just eyeball their nostrils.
I call that, we used to have them labeled like infant, pediatric, neonate, but then we had a lot of people complain, well, it's a neonate, but my kid's a pediatric technically. So we got away from labeling it. Now it's all small, medium, extra large, but I literally still refer to this purple like an infant size, green like a pediatric. Kim made the comment about like your 6 to 8-year-old, sometimes this is going to be too small. Did we talk about bigger kids?
When you're coming out with bigger sizes, you mean?
Yes.
Yes.
Okay.
Anxiously waiting.
I know. So it's like Christmas for me, literally, because any day now we're going to be having a larger size cannula. So what happens is this max flow in here is 25 liters. And we've had a lot of feedback, which is great, saying we have these kids that come in and we don't want to put them on an adult small cannula. We want to keep them on the junior because of the wiggle pads, and we'll talk about what they are. We are coming out with a larger cannula. So it's going to be, I believe, the Dolphin cannula, I think. Gray, and can go up to max 33 liters. Everyone's like, how did you come up with 33 liters? Because that's when this pop-off is going to happen. So for bigger kids, if you're in that pickle right now, we're coming out with something new. Just hang tight on that. Questions about that? Questions about high flow right now in general? Does it make sense how it's different than regular oxygen? We're heating and humidifying it. Because you can heat and humidify, you can go higher on the flows. It's an open system, it's not a closed system. And yeah, that's pretty much it. So what does your setup look like? Well, a couple things. So we have the cannulas here. Cannulas, when you open them up, now I'm doing a quick demo. They actually have these lovely, let me grab one more cannula here. They actually come with wiggle pads already attached, and I'll pass this around. You guys can look at it then when I'm done. If for whatever reason you put the wiggle pads on and one's not sticking or the kid's crying and it falls off, we have backup wiggle pads that you can use. So they come already on, but if you have to say, you know what, I need to replace one, you just grab the replacement and put it on there. So how's this different than what you're used to probably seeing for your basic oxygen cannulas, or sometimes this used to actually be our old high flow cannula? Number one, common issues you have is this kinks off the flow. So if the kid lays on it, it can pinch it off, and then you're cutting off the flow to the kid. Because we're heating and humidifying it, you want to have some form of protection to help prevent moisture from going into there. This does nothing in protecting that, okay? The other difference is this is hollow here. So what happens is you have two flows that collide, creates a loss of energy, and then you get rain out. That can happen too. So we advanced from this to this. So this is the Optiflow Junior 2 cannulas. Literally, it's kink free, so we can't pinch that off unless you try really, really hard. Everyone always asks, is this wire heated? It's not, it's unheated. It's just the skeleton to keep this membrane in place. This membrane is our Evaqua technology. And what that means is it wicks away moisture. So if any condensation starts creeping up, it tries its best to wick that away and prevent that from going into the kid's nose. You'll notice that there's a dip in our cannulas. All right, our old ones used to look flat and they would still kind of roll out of the kid's nose sometimes. Now we added this dip. So when you're placing it on the kid, you want to keep the dip there because that helps the prongs stay better into the nose. All right. And then when I hold it up to the light, it's kind of hard to see, but these flows are now independent. This is solid here. So it's much more comfortable for the kid when you go on the higher flows because you don't have that colliding energy anymore. That flows are independent and it's much more comfortable as far as delivering it to the patient. When you're getting ready to apply, you just take, it's like a Band-Aid. You just take the first layer off. Now this is a little too big for this guy. And of course it's a doll and he's not screaming and moving around, but this just applies like so, and then you just reach behind and pull off. And that's it. So the nice thing is there's no more cutting, there's no more taping. That's all you have to do as far as applying it, okay? If something is not right or the prong's stuck or you need to remove it and do some cleaning there, this has Velcro under the wiggle pads, so all you have to do is readjust, reapply. That's it. Circuitry looks like this. So the only thing I'm missing from this demo here, you would have your heated wires connected and your temp probes. This layer here acts as a shield to help insulate, to help prevent moisture from happening. I did talk about water vapor, okay, a little bit earlier. So because we have water vapor and because you're gonna be in an outside environment, colder temperatures and stuff, that will have an effect on sometimes maybe condensation being in the circuit. If you see any pooling happening, it's okay to dump it back into the chamber because it's water vapor and bacteria and so forth can't carry up to the kid. Why do we want to do that? Because we don't want it going back to the patient. So if you see any, you don't have to dump it and empty it. You can just literally pour it back into the chamber. And then this just has a nice fit connection there. If this becomes twisted for whatever reason, you saw how I was twisting it, this swivels. So again, you don't have to untwist it or undo it, you just have to untwist it and so forth. Typically we like it having behind a kid's head, the smaller ones. If it's the kids that are sitting up, then you can have it laying in front. But we also have this nice, they call it the kangaroo clip, that you can clip it to their gown, you can clip it to the bedside to kind of help take the weight off the circuit. Has everybody used the heaters before? Okay. So for infant high flow, pediatric high flow, 37 degrees, correct me if I'm wrong, that's what we recommend. So all you're doing is having this on the invasive mode here, okay? If they complain it's too hot, you can bump it down to 31, but don't be afraid to bump it back up to 37. Yeah, no. Usually that's the older adults that like to complain. I'm gonna show you this transport tubing too. For the most part, you shouldn't have to need it, but if you're in a situation where you can't move the patient from point A to point B with the heater and you have to disconnect and just use regular oxygen, we have this oxygen transport tubing. So again, we wanna try and create less taking cannulas off and on and putting multiple interfaces on as much as possible. So then this just connects onto here. This could connect to your regular O2. And then when you get to the heater circuit, you can just connect it back on like so. Okay. So that is your quick crash course on nasal high flow. What questions do you guys have for me, for Kim?
Can he ever do a treatment through that process? Or
Yes.
is that
Yes.
not acceptable?
Nope, you can, yep. The goofy thing is you need